Next talk is by Dr. Manoj. The topic is evaluating optic disc pallor. Is it glaucoma or neuroophthalmology? Dr. Manoj is professor and head of Department of Glaucoma, Amrita Institute of Medical Sciences.
Good morning to one and all. Also, let me thank Dr. Hannah for this opportunity. I'll be talking on disc pallor. Is it glaucoma or primary optic neuropathy? I purposefully did not mention consecutive or secondary because they are quite obvious. There is no confusion there. Acknowledgement to Dr. Wallace Alward, who has produced some of these beautiful photographs I'll be showing. First and foremost is to listen to the patient. It improves patient-doctor relationship and helps make the right diagnosis. Also, let me emphasize the importance of a comprehensive eye examination, which includes visual acuity, anterior segment, disc, and rest of the fundus, applanation with pachymetry and gonioscopy. But this talk will be centered around the optic nerve head. The best way to examine the optic nerve head is the slit lamp indirect ophthalmoscopy with 78 or 90 diopter lens. Use green filter for RNFL assessment. The drawback of examination technique is that it is impossible to assess the ganglion cell complex. Introduction to the glaucomatous optic neuropathy. It is a characteristic progressive optic disc cupping or thinning of the neural retinal rim. Those are the definitive features of glaucoma. The other neuropathies tend to leads to ganglion cell loss and pallor of the neural retinal rim. AON is an exception, and some of these AONs can over time develop cavernous optic neuropathy. Not all cavernous optic neuropathies or cuppings are abnormal. Some of them can be physiological. When you have a larger disc, you expect a larger cup. The ISINT rule has very low specificity, and if you go on diagnosing glaucoma based on ISINT rule, then you will produce a lot of artificial glaucomas. Calculating the disc size, if you are using 90 diopter lens, then you can multiply it by 1.3 to get the measurement of the optic disc. This is an example of the physiological cupping, about 0.7 CD ratio you can see, but you can see the neural retinal rim and NRR are healthy. Some of those abnormal situations like a tilted disc, drusense, they fall outside the preview of this talk, so I will not be going into details on how to diagnose glaucoma in such situations. The supportive signs are again supportive. They lack specificity, but we will be discussing them in the subsequent slides. First, let us look at normal optic nerve head. They are usually slightly vertically oval, and the size ranges from 1.5 to 2.2 millimeters diameter. Symmetrical usually, and normal cup disc ratio ranges from about 0.1 to 0.4. And remember that about 5% of the population can have a cup disc ratio more than 0.6. So going by CD ratio, you'll overdiagnose glaucoma. So that is not just the way. So let us look at the definitive changes of optic nerve head glaucoma. Enlarging or progressively enlarging optic nerve head cupping is definitely a sign of glaucoma. So this is an example of a patient who has been followed up for 35 years, starting with a cup disc ratio of about 0.4. It is ending up with a 0.9 cupping over 30 years. What should you look for? Examine the inner contour of the cup. Look at if it is concentrically going or there are any irregularities like a focal polar thinning. The polar thinning can be focal or diffuse, or there is a notching. There usually will be a corresponding retinal nerve fiber layer defect as well. Look at the cup disc asymmetry. In a symmetrically sized disc, when you see a cup asymmetry, then that is very specific. And disc hemorrhage in the presence of cupping is again another symptom of sign of glaucoma. Not all asymmetrical cuppings are glaucoma. If the disc size itself is larger, then the cup can also be larger. Like this case, you can see if you just look at them separately, you may completely miss this. So keep those photographs together and then compare. Also, this is evident in the OCT as well. Disc hemorrhage, unless you keep looking for it, it will be missed. And this photograph is an excellent tool to actually evaluate for disc hemorrhage. You can see an inferior neuroretinal rim thinning and a corresponding RNF defect and the disc hemorrhage on the edge of this defect. And you know that this is a sign of progression or an activity, and over time the RNF defect is going to enlarge towards the disc hemorrhage side. The other ONS changes of glaucoma, like the peripapillary atrophy, bearing of circumlinear vessels, bionetting sign, laminar dot sign, or nasalized blood vessels. Peripapular atrophy, we have alpha and beta. The beta is what is usually associated with glaucoma, but 25% of normal population can also have beta atrophy, so it is not a specific sign for glaucoma diagnosis. Bearing of circumlinear vessels. As you can see, this patient, as the disease has progressed, there is a bearing of over there. You can see that that blood vessel is not supported by the neuroretinal rim. That's called as bearing of circumlinear vessels. Bionetting is when a vessel completely disappears and then appears on the surface. So that happens in advanced excavations or advanced glaucomas. Lamellar dot spine is again non-specific. They just mean that the cup is deep. It can be physiological or glaucomatous deep cup. So when you have loss of neuroretinal rim and in that particular zone there is a lamellar dot sign, then that becomes significant. Retinal nerve layer defects are usually there and they are very obvious on dysphotography. Wherever there is a neuroretinal rim thinning, and if you have normal, healthy RNFL on either side of the defect, you will see it like it has a defect. If it's a very large area of loss, then you will not see a defect, but you will see a broad area of RNFL thinning. This is a patient who has progressed from near normal to inferior loss and a RNFL defect with a disc hemorrhage. When you have a tessellated background, you may not see the RNFL defects evidently. So OCT plays a better role in these situations. So you can see the superior NRR is thin and RNFL is broadly defective, but there is no defect as such you see in this tessellated background. Red-free images are a very good useful way of assessing the RNFL changes. This is a picture of glaucomatous optic atrophy. Optic nerve and peripapular examination is the key for glaucoma diagnosis. So can you have cupping and not glaucoma? Yes, like I already mentioned, AAN is an example. Also, when the cupping was there earlier itself and the insult happened later, so it can be any type of insult. It can be glaucomatous insults or other insults. So in such situations, it may be confused with glaucomatous optic neuropathy. Some of those consecutive optic neuropathies, like an old branch retinal vein occlusion, can sometimes come as focal inferior or superior neuroretinal rim thinning. Some of these cuppings, classical cuppings of glaucoma, are actually prior glaucoma insults, like in a steroid-induced glaucoma. And over time, as the steroids have been stopped, the IOP has come down to normal, and then they are not usually progressive disease. Can you have pallor and no cupping and still have glaucoma? Yes, it is possible in patients who have specific type of glaucomas where there is possibility of acute rise in IOPs. So such acute attacks can cause pallor. Quite often we see them in angle closure glaucoma and some of these secondary glaucomas like silicon oil glaucoma or uveitic glaucoma. Visual field defect occurs after significant physiological damage occurs. RNFL and ganglion cell changes precedes visual field defect. Let us look at a few examples. This is a patient who has a Durham scotoma, Derringer scotoma superiorly. If you see this RNFL defect, it coming close to the fixation. This angular distance is quite small. In such situations, you will have involvement of the GCC on the GCC map and a field defect closer to the fixation. This is a patient who has a wide angular width, and this field defect is away from the fixation, and that is not involving the macular GCC. This shows a primary type of optic atrophy seen in a pituitary microadenoma. There is binasal loss of GCC, bitemporal hemianopia, and temporal pallor temporal thinning on RNFL OCT. Another example, you see temporal thinning in the deviation and thickness map, a generalized depression on total deviation, and pattern deviation is looking normal, whereas total generalized reduction in the thickness in the GCC map of macula. Another example, this is the patient who I recently saw, the last slide. This patient was a non-case of primary angle closure, status post PA, IOP control on single drug, who did not have any visual field defect. Patient presented with complaints of blurring of vision 1 month prior. So examined, the IOP was normal, the disc was looking the same, but I subject the patient to a field and keep the fields together. Then you can see that there is a right homonymous hemianopia developing. Otherwise, the OCTs are looking exactly like the previous OCTs. So I subject the patient for an MRI, and this is what we got: a subacute infarct in the occipital lobe anterior to the posterior horn of the left lateral ventricle. So take home message or take clinic message. Don't take it home. Get a detailed history, clinical examination first, then correlate with available investigations. Thank you.
Thank you, Dr. Manoj, for that good talk on optic disc pallor. Can I have a question? Dr. Manoj, so with the disc, looking at the disc, when would you ask for imaging or like a neurological evaluation? What are the warning signs that would prompt you to?
Yeah, if I see a temporal pallor, that is what normally people get confused with. When you see a small pallor, is it physiological pallor like in a myope or a tessellated background, or sometimes in a pseudophakic, or is it actually pathological? I think we can first suggest the patient for at least a bare basic visual fields to see if there is a neurological pattern. If it is not there, then I don't further investigate.
Okay, thank you.